Chapter 8, Safe Medication Use. All right, here we go. Older adults and medications. So older adults who are 65 years and older are the largest user group of prescription and over-the-counter meds. Of this population, 90% takes at least one medication a week, and as we all know, because we've worked with this population somewhat, many of you have, and in the clinical setting, it's definitely 90%, maybe even more, and definitely a lot more than one meds most of the times. Older adults accumulate prescriptions as they accumulate chronic diseases and healthcare providers, and the number of drug reactions increases with the number of medications used, and we'll dig into that throughout these slides. Factors affecting prescribed medication use, so you can go ahead and read through those. These slides are available for you. I don't need to address those individually, but remember when you're doing your studying that things from our slides can be part of the test. Pharmacokinetics. So some of you guys may remember this from pharm, and actually I just taught it over the summer. So pharmacokinetics is the movement of drug throughout the body from the point of its administration as it is absorbed, distributed, metabolized, and excreted. And we're going to go through each one of those. Absorbed, for a drug to be effective, it must be absorbed into the bloodstream, right? So you want to make sure that you know that obviously it must go into the bloodstream in order to be effective. So let's start with absorption. Depends on bioavailability, and what that word means is the portion that is available to the target area or amount that is absorbed into the bloodstream. So we know that, and we'll go into this in a little bit, like many meds have a certain amount that are protein bound, and then there's only so much available for the receptors. But the bioavailability means how much is left for what it was supposed to do. So for instance, if a patient's taking a beta blocker, the bioavailability would be the portion that's available in order to slow the conduction system down. And then routes of administration include IV, oral, parenteral, transdermal, or rectal methods. Normal age-related physiological changes affecting prescribed and administering medications include the following. So an increased gastric pH will stunt the effectiveness of acid-dependent drugs. So many drugs need to have a high, like a really good acid balance in order to, or enough available in order to break down correctly in the stomach. And so if a patient that is older has a reduced amount of acidity in their stomach, then it's going to stunt the effectiveness of that medication. Stomach emptying is delayed, and intestinal motility is slowed. So remember, when we check residual on patients on tube feeding, the reason we're checking is to see how quickly the stomach is emptying. So if I pull back 200, I know that the emptying is delayed. And that patient probably needs a dose of Reglan, which increases. It works on the parasympathetic nervous system and increases gastric motility. Intestinal motility, as far as the feces that moves through the intestines, is also slowed. So that makes our patients more prone to, especially elderly, to constipation. Distribution. This is medication must be transported to the receptor site on the target organ to have an effect. So all medications have to end up on the receptor site in order to do what it's supposed to. Distribution depends on the availability of plasma protein in the form of lipoproteins or lipoproteins, globulins, and albumin. Our elderly patients have decrease in all this, so distribution can be an issue. Percentage of drug is protein bound and therefore not available for receptor sites, and hopefully you learned that in pharm about how there are many drugs, actually a huge amount of a lot of drugs or many drugs are protein bound. So once they're bound to that protein, they can't go to the receptor sites. They're done used. There's nothing for them to do. They're already taken. So the available med that's able to actually go to the receptor site. So we have to, that's another concern for distribution. And make sure that you read page 109, distribution, if you're unclear about distribution. Metabolism is a process in which the body modifies the chemical structure of the drug. The liver is the primary site for drug metabolism. Enzymes play a big role of drug metabolism. As a result of aging, the liver's activity, mass volume, and blood flow are normally reduced. So the metabolism of the drug is not going to be as great. hepatic clearance of medication is decreased 30 to 40% with aging. So if I have a patient that has a lower hepatic clearance, what's that going to mean? That I'm not metabolizing the drug the way that I should, and therefore I can end up building up a level in my body that I shouldn't have. That's going to go into excretions. So medications are excreted in sweat, saliva, and other secretions, as well as mainly by the kidneys, though. Kidney function decreases with aging up to 50% by 80 years of age. That's straight from your book. It prolongs the half-life of drug or the amount of time required to eliminate the drug. So again, let's go back to what we were just saying. If I'm not excreting the drug out of my body, it's building up, and I can have toxic effects, which can be very, very dangerous for those medications in which have a low therapeutic index. And if you remember therapeutic index, we talked about this, is when the toxic level and the therapeutic level are very close to each other. If you guys recall from mental health, we talked about lithium being that way, and there's other medications as well. I mean, think about DIG and meds that if they were to build up too much, they're going to cause a major problem. Pharmacodynamics, this is the interaction between the drug and the body. So there's drug-to-drug interactions, different medications, and we have so many programs now that will tell docs and nurses if these meds should be prescribed together and if what the level of severity of an interaction could possibly be. And it'll cue us into if these meds should be both ordered or not, and then it becomes a risk versus benefit. But again, if more than one drug is competing for the same receptor, the bioavailability, which we just learned, of the medication is changed. Because if I can't get my one medication on the receptors, then I'm not going to have nearly the effectiveness that I would have. And then herbal preparations and medication interactions. So instead of putting this all out on slide form for you, I've just included page 111, table 8.3 is the herb medication interactions. It's a nice little, pretty, it's not super involved table that actually does a nice job with it, so make sure you read that. Chronopharmacology is the relations of biological rhythms to the variation in the body's response to drugs. It is a developing science that may lead to more effective drug therapy. So basically what this is saying is the time of day in which the patient will take the medication, the biological rhythms can change, or the drug effect can be changed based on the biological rhythm. So for instance, patients take Synthroid at 6:30 in the morning, because if they were to take it at night after a long day and having food in their stomach all day and doing all their activity, then they would be up all night. But not only that, it just works better if taken on an empty stomach early in the morning upon rising, because it gets the body going for the day. It gets the hormones going that normally the thyroid would produce and take over, so the patient has that. So we're learning more and more about time of day for certain medications. Obviously, a medication like trazodone is best taken at night because it's going to help induce sleep. It causes that sleep induction. So, we're learning more and more about this. Medication-related problems of the older adult. So polypharmacy is defined as taking more than 5 medications at a time. 2 major concerns with polypharmacy is the increased risk for drug interactions and increased risk for adverse effects. Drug to food, nutritional supplement, or alcohol interactions. Remember, we got a lot of foods out there, or a lot of drugs out there that can be taken with grapefruit juice. So we have to look to see, is there any kind of drug to food interactions, and obviously alcohol interactions, and we learned quite a bit about that in mental health, especially with like benzodiazepines and other addictive substances or things that cause sedation. An interaction results in altered pharmacokinetic activity, so that's the absorption, distribution, metabolism, or excretion. Adverse reactions range from minor annoyances to unwanted pharmacological effects, and reactions can result in a death. That's an adverse reaction, is death. Older adults are 4 times more likely to be hospitalized from adverse reactions. You also would have your allergies to these and adverse reactions as well. They are not always predictable. Sometimes we know there's a possibility for them, but we can't ever know because every person is different the way they react to medications. Commonly observed adverse reactions in older adults include drug-induced delirium and confusion, lethargy, and sexual functioning. Inappropriate medications Their potential for harm is greater than their potential for benefits. So remember, risk versus benefit. So here we're finding the flip side of it. Normally we talk about, well, we give it because the risk versus the benefit's greater. Well, here the potential for harm is greater than the potential benefits. So that would be considered an inappropriate medication. And there's this Beers list that your book talks about that identifies drugs that carry a higher than usual risk when prescribed for older adults. And on page 115, table 8.5, list of inappropriate meds. Go ahead and make sure you read through those. Misuse of drugs. Misuse is accidental, typically, includes overuse, underuse, erratic use, or contraindicated use. As more drugs are taken, the chance for misuse increases. Misuse is related to a misunderstanding or the inability to read the labels or follow the instruction, or the memory has failed. There's other things in your book in that section as well that talked about that, but those were the three I decided to grab from there. Implications for geri nursing and healthy aging. Methods for obtaining a drug history is performed by a comprehensive medication assessment. So remember that med reconciliation that we've been talking about over the last couple of terms, that we want to do a med reconciliation on every patient when they come in. And then 24-hour medication recall. We want to monitor and evaluate the effectiveness of a medication regimen. And also please see box 8.3 on page 117. Patient education regarding medication therapy. So we want to talk with the key person who manages the person's medication. So this may very well be the patient, but if not, somebody else. The environment, we want to teach them to minimize distractions. So turning off the television or not answering the phone while they're doing their medications. Timing, we need to teach them what is the best time. So again, going back to medication that should be in the morning or in the night, or what's best for the patient if there's not a specific time that's needed. Communication, we need to make sure that we will be understood by the patient, okay? So if they need their hearing aids in, or they need their glasses to watch or read something along with us, we want to make sure they're going to understand what we're saying. Reinforcing teaching, we want to provide memory aids. So, like a lot of times in the teaching environment for me, I'll give you something to help you remember an idea or a concept. Same thing for your patients when teaching them about medications. We want to give some kind of cue that can lead them back to, oh yeah, that's right. LOL, that's funny. It's going to make my heart go down, though. I mean, that is obviously not a good one, but I'm just making something up. But you know that you want to make sure that you give them some kind of memory cues to know. Evaluate your teaching, so you're going to have the patient repeat back the info to you. You're not going to tell them and have them repeat it verbatim. You're going to teach it and then say, okay, tell me what you learned about your metoprolol. Tell me what you learned about your insulin. When would you take that? And then have them give you the information. If they cannot, you need to teach it again. And then avoiding drug interactions. One of the biggest keys is teaching them to use one pharmacy, and also teaching to try to have all of their different providers coordinate, because we have, they have a cardiologist, they have a pulmonologist, they have their primary doc, all these different patient or docs prescribing meds. Medication administration, so there's difficulties opening bottles as a result of arthritis and just weakening. The use of pill cutters, difficulty swallowing medications. This is due to size of meds, because we know we give a lot of horse pills out. Dry mouth, all of the medications they take cause dry mouth. Then they have a hard time getting it down. Use of accurate medication measuring devices. Proper administration of enteric-coated, extended release, or sustained release. So remember, these are do not crush medications. And use of transdermal patch, and the book talked about how it's not recommended for persons that are noticeably underweight, and the reason is because they don't have a lot of fat and tissue to absorb the medication, so therefore they'll have higher levels in their body. Psychoactive medications, we can talk about these again together, but we did these extensively in psych, so they're listed there for you, but I thought if we need to talk about them, we'll talk about them together. And then implications for geri nursing and healthy aging. All medication classifications represented have indications for their use, side effects, interactions with other medications and herbal drugs, and the client's reaction to the medication. The geri nurse needs to assume that all medication uses are appropriate, effective, and safe to use. And nurses are often the ones to initiate the assessment of medication use, evaluate the outcomes, and provide teaching.